Okay, good morning, everybody. So it's 9 a.m. So as promised, today is a lecture. I will be giving a lecture on hypertension for pathophysiology with its pathophysiology and also complications, and a little bit on investigation regarding the hypertensions. So for those who haven't scanned the QR code for attendance yet, I will display it again after my lecture, at the end of the lecture. Okay, and because today there's some construction going on at the outside, just outside my room, so there will be some noise. So if you have troubles listening or hearing what I said, you just turn on your mic and stop me there, and you can ask me uh, along the way, or you can have a look at the recording afterwards. All right, so let's begin. All right, so hold on. Okay. Okay, so this is the outline of my lecture. This is again, it's a very short lecture. I'll be talking on the pathogenesis of hypertension. How does hypertension happens to be, and also the complication and the pathophysiology, explaining towards the complications of the hypertensions. Okay, etiologically, hypertension can, or the causes for hypertension can be divided into, hypertension can be divided into two: essential hypertension or secondary hypertension. And the etiology or the causes for these types of hypertensions is a little bit different. For secondary hypertension, you can see there are multiple causes. This is just some example that I list here. You can see in my previous lecture notes, there is a lot of list of secondary causes for secondary hypertensions. So, but in this case, in this lecture, I will just show you some of the examples of the causes for secondary hypertension. For example, it can cause from the renal problems, or for example, in acute glomerulonephritis or chronic renal disease, there's a problem of renals. As you know, as you learn in the physiology lecture, renal is one of the organs that control the blood pressure. Next is the neurological problem. For example, in psychogenic, increased intracranial pressure, sleep apnea, acute stress, and also including surgery. So all of this can cause can cause hypertension. Next is endocrine, for example, adrenal hyperfunction, for example, in patient with Cushing syndrome or pheochromocytoma. There's some hyperfunction of adrenal cortex and also adrenal medulla. So it will cause hypertension. So these hormones can increase the blood pressure by their own pathway. You can review back your physiology lecture. And apart from that, exogenous hormones, for example, glucocorticoids in patient with SLE, or sometimes in patient or person who intensely go to gym taking anabolic steroids. So these steroids also can cause hypertension. Apart from that, estrogen, for example, in patient with who took OCP or pregnancy pills, so which contains a lot of estrogen. So these will also raise in the blood pressure. Next, for cardiovascular system, for example, in coarctation of aorta, where there's a stricture of the aorta congenitally. So this also will cause hypertension secondary. But bear in mind that secondary hypertension only consists around 5 to 10% of majority cases of hypertension, whereas for the essential hypertension, it comprises around 90 to 95%. So it means that essential hypertension that causes that 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 has a multiple causes. For example, from due to diets, due to environmental factors, this occurs around 90 to 95%. They don't have any clear secondary causes that causing the hypertension in this patient. All right, next is for the pathogenesis. So as this is just a simplified arithmetic or simplified algorithm, just to mention or to show you on regarding the control of blood pressure. So blood pressure is controlled by cardiac output and also peripheral resistance, total peripheral resistance. So these two things or two factors influence the blood pressure. So the cardiac output and also the, and the peripheral resistance. All right. So for the cardiac output, the one that control it is the blood volumes and also the cardiac factors. So there are two things that control the cardiac output. Cardiac output means the amount of blood going out from the heart. So that is what basically just a rough translation of cardiac output. So it is controlled by the blood volume. So it means is if the blood volume is high in a person, so the cardiac output will increase. So you can see in these cases of sodiums, mineralocorticoids, and also where natriuretic peptides, all of these factors controls the blood volume. So it means that if there is an increased sodium, so there will be increased blood volume. And also if there is an increased natriuretic peptide, it will increase the sodium and then increase the blood volume. And for the cardiac factors, if there is an increased heart rate and increased contractility, they will also increase the cardiac output. So it means that if the heart rate is high, so for example, if you compare the cardiac output of a person who has 60 beat per minute of heart rate and a person with 120 beats per minute of heart rate, so of course the higher number of heart rate will cause increase in the cardiac factors and also increase in the cardiac output. This is same as the patient who had very thick ventricular muscle, especially the left ventricular muscles. So if the patient or the person who has a congenital hypertrophy of the ventricles muscles, so it will increase the contraction rate of contractility of the heart, and this will also increase the cardiac output. For the peripheral resistance, usually it's controlled by humoral factors, mean hormonal factors, and also the neural factors or the nerve factors. For the humoral, there are a lot of constrictors, for example, angiotensin 2, catecholamines, thromboxane, leukotrienes, and so endothelin, all of these are constrictors. And also for the neural factors, there are two, can be divided into two. Either it's a constrictors and also dilators. Constrictor is usually alpha adrenergic type. Dilators mean beta adrenergic type. Also, this one I won't go into details because it's already been taught to you in the physiology lecture. So constrictor and also dilators here means that it constricts the blood vessels and also dilates the blood vessels. So if it is constrict the blood vessels, it will increase the peripheral resistance, thus increase the blood pressure. Or if it is dilators, it dilates the blood vessels, thus reduce the peripheral resistance, then reduce the blood pressure. So this is the control of the blood pressure. Basically, this is just a simple explanation because I won't go into details regarding these topics because it will be a very lengthy lecture. And you can, and I think it's already been taught in the physiology lecture previously. All right, so back to our diagram here, cardiac output times total peripheral resistance equals to blood pressure. So based on this, you can tweak or help you, it will help you in determining or in explaining how does the blood pressure increase or how does a patient or a person has hypertensive. So it means if cardiac output increase, blood pressure increase. If peripheral resistance increase, blood pressure increase. If both are increased, blood pressure also increase. So it's a direct effect of the factors will have a direct effect on the blood pressure. All right. First, I will go explaining regarding the increased blood volume, which is commonly seen in the hypernatremia. Hypernatremia can be seen in nowadays because a lot of food that we take or we took is highly seasoned. There's a lot of sodium intake, for example, in common table salts or monosodium MSG. All of that contain a high amount of sodium. So if you go to a fast or takeaways foods, usually they contain a lot of sodium because sodium, of course, will make the food taste better. So if there is an excess sodium intake, there will be hypernatremia. Hypernatremia means increased sodium inside the blood, in the blood serum or the blood. So when there is a hypernatremia, usually it won't come alone. So this sodium will attract water, and it will cause water retention because our body will try to normalize the sodium within our blood. So in order to do that, it is either increase the intake or reduce the excretion of water. So increase intake, of course, it will stimulate thirst center, and the person will increase water consumption, or it will reduce the urine output, so that the water will be kept inside the blood vessel, so it will neutralize or normalize the sodium level. So because of this, the blood volume will increase. So when the blood volume is increased, it will eventually increase the blood pressure. So this is another the way it affect the blood pressure. Next is the hypoaldosteronism. So hypoaldosteronism is caused by the problem inside the adrenal glands. So it can be primary or secondary hypoaldosteronism. So this will be talked in depth when you go into the endocrine blocks or endocrine cause. But bear in mind, at this point, you just remember there's increased hyperaldosteronism where there is an increased mineralocorticoids, in which these hormones will cause reabsorption of sodium and also water. So when sodium and water being reabsorbed back into the blood, it will increase the blood volume, thus increase the blood pressure. So this is a simple way to explain regarding the increased blood pressure in the hyperaldosteronism. But there's a long pathway, but you can combine it with the physiology and also the knowledge that you can gain from the endocrine cause. I think maybe later. All right. So usually the primary hypoaldosteronism is caused by adrenal hyperplasia and also Cone syndrome, adrenal adenoma. So all these two things, or these two pathology will cause the primary hypoaldosteronism. For the secondary hypoaldosteronism, usually if the patient had a massive ascites, left ventricular failure, core pulmonale, proximal renal tubular adenosis, this will stimulate the release of hormone, mineralocorticoids hormone, thus will go into this pathway. So all of the secondary things is causes for the hypoaldosteronism. Next is the increased blood volume, where there is increased sodium resorption in Liddle syndrome. This is a very rare syndrome when there is a genetic mutation at 16p, 13p, 12 chromosomes. There will be a dysregulation of epithelial sodium channel. So the sodium channel is defect in this case. So what happened is it increased the amount of sodium channels, and then it will increase resorption of sodium. Again, sodium is coupled with water, and then because of this, it will increase the blood volume and then increase the blood pressure. Next is increased sympathetic tone in pheochromocytoma. So pheochromocytoma is a problem or a lesion or a pathology that happens to be in the adrenal medulla. So when there is a pheochromocytoma lesions or pathology, it will increase the secretion of catecholamine. So what catecholamine do is it cause vasoconstriction. So what vasoconstriction does is it increase the peripheral resistance. So meaning when it is increased, when the blood vessels is constrict, so it will put some resistance toward the blood flow. So this what will cause increase in blood pressure. So you just remember when it's constrict, it will increase pressure by increase the resistance. When it's dilate, it reduce the peripheral resistance, thus reduce the blood pressure. So that's how it works. So you need to understand this actually from vasoconstriction up until the blood pressure, because during your practice as a medical doctor afterwards, you need to understand the mechanism of actions for each drugs. This will help you because some of drugs will have a vasoconstriction effects and other drug will have other effects. So if this will help you to better understanding on um, the the medication that you give to the patients, how which one is good for each type of hypertensive patient. All right. Apart from that, for the increased peripheral resistance is also caused by vascular abnormalities. For example, in atherosclerosis or arteriolosclerosis, in which the lumen of the vessels is narrow. Both of these things, arteriolosclerosis usually caused by increasing age, where the small arteries become hardened due to calcification that are found in the arterial wall. And for the arteriosclerosis, there will be increase in the thickness of the intimal layer that cause the lumen to become narrowed. So this narrow lumen will increase the peripheral resistance and then increase the blood pressure. As previously I mentioned, when there is constriction or reduce in the lumen size, there will be increase the resistance. So meaning the blood flow is a little bit difficult to channels through that narrow lumen. So this will increase the blood pressure. It's just analogically, you can compare if you have tubes, pipes, rubber pipes that you spray water with. When you make the lumen or the outlet of the pipes or the tubes become smaller, so the water pressure will become increased. So that is how it happens in our blood vessels. So when the lumen is narrow, the pressure is increased. All right. Enough about the pathogenesis. So now we go into the complications and also pathophysiology. So this is just, I think, majority of you had already known and already discussed regarding the this complication and so pathophysiology in your PBLs. But this is just another repetition, and you can sit back and enjoy the rest of the lecture. All right. So again, blood vessels can be divided into two. The lesion or the complications of the hypertension towards the blood vessels can be divided into two. Number one is the degenerative changes in small blood vessels, in which you can see hyaline arteriolosclerosis and also hyperplastic arteriolosclerosis. And another one is arteriosclerosis, in which I've already given to you the lecture in the past 2 days. Okay, number one, hyaline arteriolosclerosis. So you can see these are one vessels here. You can see the lumen is very narrow. So actually, if the vessel is like shape is this one, the lumen should also become widened as or almost as wide as the vessel's diameter. But in this case, you can see the white part here at the center here is the lumen, in which it is very small and almost slit-like shape. So this will increase the blood pressure in the increase the peripheral resistance in this not in this page in this case. But how hypertension also can cause this problem by when there is a high blood pressure, they become injured endothelial. So the endothelial is the lining inside the lumen here. It will become injured, and this injured endothelial is, as you know, become very porous, very leaky, uh, and some of the plasma materials from the blood can seeps uh, into the extracellular matrix. This will increase the extracellular matrix production. Extracellular matrix is the matrix that contains or present just beneath the endothelial lining. So all of these matrix will become increased in the production, and this will increase the hyaline thickening. So this type of lesion is usually found in a patient with benign hypertension. That means that the hypertensive is not that high in this patient. So it becomes slowly injured and slowly become thickened. So it has some times to become proliferate and also increase the production by time. So in a benign hypertension, you can usually can see or can find this type of lesion in their organs or tissues. So here's again another features. You can have a look afterwards. And next, in patient with severe or malignant hypertension in which the blood pressure is consistently high or persistently high, more than 180, 190, sometimes persistently 200 of systolic pressure over 100 or 110 pressure of diastolic. So in this type of patient, usually you will find this type of lesions in their vessels, in which we call it hyperplastic arteriolosclerosis. So you can see a concentric laminated thickening of arterial wall with luminal narrowing. So just to help you orientate, at the center here is the lumen of the vessels, and the rest here is the vessel's wall. So you can see there's a lot of nucleus here, here. All of this blue purplish color thing is actually the nucleus of the endothelium. So it become hyperplasia, hyperplastic. So it increased in the numbers of the endothelium. Endothelium. So that is why you can see it look like onion ring, onion skin inside these lesions. All right. So how does this happen? Because there's a severe hypertension, the vessels wall become injured, and also sometimes because it's persistently high, sometimes some of the vessel wall is necrotic, become died. So in order to replace this necrosis or necrotic tissue or cells, it will increase the smooth muscle proliferation and duplication. So because of the increase in the smooth muscle proliferation and reduplication of the basement membrane, so that is why you can see there's a layering of the cells here. So all of this contributes to the formation of hypoplastic arteriosclerosis. So again, this is just to show to you that it resembles the onion skin as you cut it. Next is the arteriosclerosis, in which I won't go into detail. You can refer back to my previous lectures. So this is arteriosclerosis, and also this is how it happens. So bear in mind that arteriosclerosis, and also hypertension is it can happen vice versa. It means that if someone with hypertension, it can cause it can stimulate arteriosclerosis formations, and in arteriosclerotic kind of patient, it can cause hypertension. It can be vice versa. So you need to investigate. For examples, the easier way to understand it is that in a patient with hypercholesterolemia or hyperlipidemia, you can see that in their blood vessel is at risk or is easily to develop or to form arteriosclerosis. So when arteriosclerosis is formed, this will cause increased total peripheral resistance of the blood vessels. So when there is increased total peripheral resistance of the blood vessels, this will increase the blood pressure in this type of patients. So it starts with hyperlipidemia first, and then they develop atherosclerosis, and then it develop hypertensive. But in hypertensive patients, increase in the blood pressure will cause endothelial injury. So this is endothelial injury. So when there is endothelial injury because of high pressure inside the blood vessels, it will cause monocytes to attach and repair the destruction or the injury inside of the endothelium. So this monocyte again will enter the intimal layer of the blood vessels and transform itself into macrophages. And these macrophages will engulf all of the lipids or cholesterol that pass through the blood vessels inside the lumen here, and it will engulf. So here is, remember, the lipids here will enter through the leakage here, and the macrophage will all eats the passing through lipids and also cholesterol. So it become foam cells. So these foam cells also stimulate the migration of the smooth muscle from the media part beneath here into the intimal part. And this smooth muscle also sometimes will absorb also the lipids that are entering the intimal layer. And then both these foam cells of the macrophages foam cells and also the um, smooth muscle cells will become necrotic and rupture and cause necrotic center of the atherosclerotic plaque. So it means that, to simplify this thing, is it start with hypertension first due to any causes of hypertension, and then this hypertension will injure the endothelium of the blood vessels, and this will cause atherosclerotic formations, and then the complication of atherosclerosis will come afterwards. So this start with hypertension first and end with the atherosclerosis. So it is a vice versa. It can be reverse or forward, but it depends on the causes and it depends on the etiology of the disease in this type of patients. So you need to understand that and then investigate the patient further to understand in what are the things that causes atherosclerosis or complication of atherosclerosis in this patient, and then you can tackle it by giving diet therapy or medications that are suitable for this patient. Okay. Next is the complication that you can see in the heart. The complication that you can see in the heart is the left ventricular hypertrophy. So meaning the left ventricular hypertrophy will become increased in the size. So usually the left ventricular walls is around 2 cm. This is the average. Sometimes it depends on the person or and ethnicity. Some of ethnicity or some person will have a thicker ventricular wall, but some other are less thicker. But you can see it's around 2 cm. Around 1.2 to 1.4 cm. But if there is the ventricular wall is more than 2 cm, then we consider it as to be left ventricular hypertrophy. And also sometimes you can weigh the heart, especially in postmortem. That what we do when we remove the heart, we can weigh it. So the weight of the heart usually, if it exceeds 500 grams, so we consider it to be hypertrophic. But it depends also when we have a look at the gross features, either it is really hypertrophy or not. But for the normal heart weight, the weight of the heart is around 250 to 350 grams. All right. So I can see this is a cross section of the heart. You cut it, I think, sagittally, so you can view the red one. The one that I circle is the left ventricles, and this one, the smaller one, you can see the, sorry, I will put this one. This one is the right ventricle. So you compare the wall of the wall of the right and also the left is a bit different. The left is always a bit thicker. You can see in this normal specimen, the wall is thicker on the left side compared to the right side. All right. But in this case, in which there is a left ventricular hypertrophy, you can see the thickness of the wall is very, very increased. So these are the ruler here. I think they put it in, metric 1 cm. So it is more than 2 cm here. Sorry, I don't know what. Oh. Sorry, can you everybody hear me? I'm so sorry because my laptop is out of battery. Let's start again. All right. Okay. So back to our lecture. Sorry for the disruption. Forgot to on my plugs. The power source for my laptop. Okay. Okay, back to our lecture. So this left ventricular hypertrophy, if you compare the hypertrophy and also the normal, you can see there's increase in the thickness of the left ventricular wall. So here is very thick, almost more than 2 times or 3 times. I think almost 4 times the thickness of the normal left ventricular wall thickness. All right. So histologically or histopathologically, you can see the left side is the hypertrophy and the right side is the normal. For the hypertrophied muscles, you can see there's an increase in the width of the myocardium. So hold on. Okay, so the width of the myocardium will increase if you compare this side, this measurement compared to this measurement of the normal myocardium, it is increased in number. And apart from that, the nucleus of the myocardium is also increased in size. It's almost double or more than double, almost 4 times the size of a normal myocardium and the nucleus of normal myocardium. So it is increased in size. All right. So how does the heart become hypertrophic? So it is pathophysiologically when there is an increased systemic blood pressure. So when you're talking about pathophysiology, you need to start from the disease itself. So meaning we start from the blood pressure, increase blood pressure first. So increase blood pressure will increase the contractility of the heart. This is because the heart is trying to pump the blood to the systemic uh, efficiently, because the systemic organs need blood flow, but the pressure in the systemic vessels is increased, so the heart needs to work harder in order to deliver the blood from the heart to the systemic organs. So you need to work hard, and because of the heart is consists of a myocardium, which is muscles. Uh, so this muscle eventually, by time, it become hypertrophic myocardium. So like if you go into the gym, you lift up some weights for, let's say, a year daily. You go to the gym daily to lift weight for a year, then your muscle will become hypertrophy or become enlarged. So this is also what happens to the heart when they increase the contractility, increase the in the uh, in the work of the heart. It will eventually become hypertrophy and become enlarged. So that's why it become hypertrophy. So what we need to understand is the sequelae of the hypertrophy, left ventricular hypertrophy. So because of the presence of hypertension, it causes left ventricular hypertrophy, and this left ventricular hypertrophy eventually will have some other complications. So these complications actually tie together with uncontrolled hypertension. So you can, number one, you can see that the one that I circle here is the coronary vessels. Usually the coronary vessel won't go penetrates into the muscles. It will just encroach, or it will just travel just outside the pericardium, or the outside of the heart sac. So it will supply the blood. It will supply the myocardium, or the of the heart. So at this, when the heart become hypertrophied, this green area is very near to the coronary artery. So when it is near to the coronary arteries, it will obtain, or it will get a very good blood supply, oxygen, nutrients, and everything. But this part over here, in which is a more deeper part of the myocardium, usually they will receive a very minimal amount of supply from the coronary artery, because it is seated far away from the coronary arteries that can supply them. So in this case, it will put this patient or this person at risk to develop myocardial infarction. So that is the number one complication, or the sequelae for a patient with left ventricular hypertrophy. So they are very at a very high risk to develop myocardial infarction or acute coronary heart disease, because of the nature of the thickness, because of the thickness of the ventricular wall. And left ventricular hypertrophy also may lead to heart failure, because by time, if it is not treated, if it is not controlled well, the heart will become sort of lethargic, or the muscle is not efficient enough to pump the blood, and this will cause the heart failure. So to understand this, what you need to understand is the blood circulation. So it is a closed circuit kind of circulation, but bear in mind, bear with me. I will start with left atrium. So the blood in the left atrium is pumped to left ventricles, and then it will go into aorta and pass to the systemic circulation. From the systemic circulation, it will go into the vena cava, and then go right into the right atrium, right ventricles, and then right ventricle will pump the blood into the pulmonary arteries, lungs, and from lung back to pulmonary vein, and also back into the left atrium. So all of these circuits will continue throughout our life. So what we need to understand in left ventricular hypertrophy with heart failure, there's two separate things or two separate uh, part in the circuit that we need to understand, or we need to understand for us to easy for to make it easier to explain regarding the complications of the of the left ventricular hypertrophy with heart failure. So number one in the red is the what I usually use is the backward failure complications, and the green one is the forward failure complications. So if you divide it by these two types, you can easily understand and explain regarding the complications of heart failure in this patient. All right. For the forward failure, I will go forward failure first because it's just one, how do you say? It's just a simple explanations. Because of heart failure, so if the heart failure is it fails to deliver its functions, so the heart will have a reduced cardiac output. So meaning that the blood that are pumped out from the heart is very reduced in volumes. So there will be a reduced cardiac output. So when there is a reduced cardiac output, there will be reduced systemic blood supply. This will cause patient to develop lethargy, sinus, and so clubbing. So all of these things is a, a thing that are caused by the forward failure. So meaning if the heart fails, it will cause the patient to become lethargic, sinus, and so clubbing. But apart from the forward failure, there's also a backward failure, which I describe it as because of the heart fails to efficiently expel all the blood that coming into the ventricles, the left ventricles, it can cause congestion effects toward the backward system. So this will cause the backward failure. It starts with the congestion in pulmonary veins. So if we look back this one, so when there is a when there is a pulling of blood because of the inefficient heart to contract to expel all of the blood, so it will become congested and it will become backward congestion into the left atrium and then backward congestion into the pulmonary veins. All right. So this is what will cause backward failure, and then congestion in pulmonary veins will be backward. It will cause congestions in the lung. This will cause pulmonary edema, pulmonary pleural effusion. So these are the complications of the left ventricular heart hypertrophy with heart failure. So apart from the problems inside the lung itself, when there is a congestion in the lungs, so this will total sum up the congestion inside the pulmonary arteries, thus cause cor pulmonale, increase in the pressure of the pulmonary arteries, and then cause congestion of right ventricular and also right atrium. So it will become backward failure, backward congestion also. And this congestion thus will cause congestion of the systemic organs. For example, patient can present it with hepatomegaly, splenomegaly, lower limb spitting edema, and also ascites. And all of these things are caused by the backward failure. So this is how you explain the pathophysiology of all these conditions that are related with hypertension, with left ventricular hypertrophy, and also heart failure. So these are all the problem, or all of the complication or sequelae of the uncontrolled hypertension. All right. Apart from heart, apart from the blood vessels, inside the brain also there will be some complication. The most common one is the stroke or the cerebrovascular accident, or sometimes they use a short form CVA. Pathophysiologically, when there is hypertension, it causes arteriosclerosis, as I mentioned. And this arteriosclerosis is a very fragile, a very soft kind of structure. So it is at risk to become rupture. So if there is a still increase in the blood pressure, it can cause rupture of the atherosclerotic vessels. Thus, sometimes it can cause thrombosis, or sometimes it can cause rupture of the whole vessels. And if it is thrombosis, it develop into ischemic stroke. If it is rupture of the total vessels, it cause hemorrhage. We will cause hemorrhagic stroke. Some of the ischemic stroke that we can see in the patient is usually caused by lacuna infarct. It's just a few millimeter size. So the common site is the basal ganglia, thalamus, internal capsule, deep white matter, and also pons. For hemorrhagic stroke, usually it's also small vessel. If it is small, you can see a slit hemorrhage with surrounding brownish discoloration. But if it is big, then you can see cases like this. For example, in the autopsy, patient died of unknown causes. Then we examine, and then sometimes we can find this type of conditions where there is a lot of there is massive areas of hemorrhagic stroke. So for the ischemic stroke, for example, in this lenticular striate vessels, a branch of medial meningeal arteries vessels. So in these vessels, if there is atherosclerosis formation within these arteries, and these atherosclerosis become rupture, and then thrombogenesis occur at this artery, it will block the circulation and prevent the blood flow from entering or circulate to the proximal part of this blockage. So when this happens, there will be some infarction can be seen inside the patient brains. So sometimes you can see this type of infarction, where we call it lacuna infarct. Lacuna means like semicircular wounds. So that is how it looks like inside the brain. Next is the hypertensive encephalopathy. So this hypertensive encephalopathy does not caused by any blockage in arteries or blockage in the vessels, but it is caused by acute hypertensive encephalopathy because sometimes the blood pressure can shoot up, the diastolic pressure can shoot up more than 130 millimeter mercury. This will cause increase in intracranial pressure and also global cerebral dysfunction. Patient can present it with headache, confusion, vomiting, convulsion, and also coma. For the brains, if we examine the brain properly, we can see there is a brain edema with transtentorial or tonsillar herniation, meaning there's some brain matter herniate into the in between the meninges layering. And if there is herniation, you can see petechial hemorrhage and also fibrinoid necrosis of the arterioles. All right, so here is example of cerebral edema. So this is cerebral edema on your right side. On the left is a normal. So if you compare side by side, the sulcus and also the gyrus, the sulci and also the gyri of the brain in the edematous brain is lost. So the brain will appear to be smooth like this one, very, very smooth. Whereas in the normal brain, you can still see there's a crooked area of sulcus and also the gyrus that made the brain external surfaces. So this is how cerebral edema looks like. So if there is a very high or very high intracranial pressure, it can cause herniations, especially in cases of cerebral edema like this one. You can see there's it will cause some brain herniation. So there are three brain herniation that are commonly seen in the brain. Number one is transtentorial, in which the temporal lobe compressed against free margin of the tentorium. So this is the tentorium. 10 means like 10 like a 10 where you go camping and everything. That is 10, because if you examine inside the brain, it looks like a 10. So that's why we call it tentorial. So transtentorial meaning it's moved from this part to this part, so it's transtentorial. So it will affect the third cranial nerve and also the posterior cerebral artery. Gross findings, if we examine this part in the autopsy. You can see Conrohan's notch and also some Durex hemorrhage. I will show you afterwards. Next is the tonsillar herniation. This is usually fatal, in which the part of the cerebral tonsil, so cerebral tonsil is at this part here, it will push towards the downward into the foramen magnum. So this will affect the respiratory and also cardiac center, in which it is the respiratory and cardiac center is almost at this part. So when it is compressed, it will damage that centers, and this patient will eventually die slowly, or subsequently become is fatal to this patient. Another herniation is the subfascial sign, which is, but this is one is not that fatal, but can cause some if morbidity in this patient. So direct hemorrhage will look like this. If you examine, there's a this part is the direct hemorrhage. The surrounding is ongoing hemorrhage, a small microscopic hemorrhage is going on. So that's why it looks like a bit reddish in color. So this part is just another hemorrhage, blackish reddish in color, inside the brain parenchyma. And just a little bit on the investigation in hypertension. So in order for you to look more professionals, or look a little bit organized, you need to classify your investigation into this into some classifications. For example, I give you an example here. You can classify your investigation into three things. Number one is to investigate the etiology or the causes for hypertension. Number two is to screen for the complication of the hypertension. Number three is to prevent the complications of the hypertension. So it's a bit different, screen and also prevent, right? So to investigate, you need to investigate the etiology of the hypertension. Means that you need to find the causes for hypertension in this patient. So what you can do is some investigation is like 24-hour urine VMA. This one to look for pheochromocytoma, hormones levels. So you need to investigate the hormone levels that cause the hypertension, and also sleep study in patient with sleep apnea. They can develop hypertension, especially essential hypertension is caused by not majority, some are caused by the sleep apnea. So you need to do sleep study, and also sometimes MRI, you have to look at the brain to rule out any neurological problems for this in this patient. Next, to screen for complications. So what you need to do in order to screen for complication, you need to do some fundoscopy, renal function test, to look at the renal function, or either this hypertension can cause renal hypertensive nephropathy. ECG to look for the changes in the heart. For example, patient can develop left ventricular hypertrophy, also can be detected from ECG and also chest X-ray. Apart from that, ECG also is a good tool to rule out if there is some some coronary artery diseases that you can see in the ECG. Also, you can detect it through ECG. And the last one is to prevent the complications. So to prevent the complication, what you need to do is to check serum cholesterol, so that if the patient had increase in cholesterol, so you need to give some lipid cholesterol medication or lipid lowering drugs, so that the patient won't progress into the atherosclerosis in a fast way compared to if you don't treat it. Liver function test is also an important role. If the patient had congestive heart failure due to left ventricular hypertrophy due to hypertension, so you need to see the liver function test. If the liver function test is deteriorating, so you need to maybe arrange for ultrasounds, and also make sure that the patient control his water intake, so that it won't congest the liver that much. So these are how you classify your investigation, so that it looks more nicely, and you will have some purpose on in answering your questions afterwards. Right. By that, I end my lecture. So if there is any questions, we have around 5 minutes before you go for practicals afterwards. Any questions, you can just turn on your mic. Sorry for the disruption previously. All right, for those who haven't filled in the attendance, just fill in the attendance. I'm not strict with the attendance, but the academic office still needs you to fill in the attendance as requested. So if there is no questions, you can dismiss and yeah, okay, sorry.
I am Adrina. I have a question. Is there like any significant difference in between myocardial infarction and ischemia?
Okay, it's actually I say it is a spectrum of disease. It start with ischemia first, mean there is a reduced blood supply, oxygen and so nutrient to the heart first, so it become ischemia first. If the ischemic conditions or the causes for the ischemia is not reduced or not being removed, for example, if the patient had coronary arterial disease, mean there's a thrombosis at his coronary artery, and if this condition is not being removed, it will progress into infarction. Infarction means the myocardium will start to become necrotic, died, and become unfunctioning. So it is a spectrum of disease. It starts with ischemia first, and it progresses into infarction if it is the symptoms or the causes is not being released. I hope that answer. Understand? Okay.
All right. Thank you,
Okay.
doctor.
Sure. Any more questions? So I will give you another minutes. So if there is no more questions, I will end in 1 more minutes. All right. Thank you for your attention towards my lecture. And I hope you have a nice day and a nice practical, I think physiology afterwards. So have a nice practical afterwards. And goodbye.
Thank you, doctor.
Thank you, Doctor.